What's up, CyberMDs, and welcome to another Step 2 cardiology lecture. Today's lecture will be covering ACLS, which stands for Advanced Cardiac Life Support. In addition to that, we'll be covering the management of other life-threatening arrhythmias that are commonly encountered on Step 2, as well as in clinical practice. Remember to like, comment, and or subscribe so that we can continue to provide free medical education resources for students all around the world. Let's get started. First and foremost, let's define advanced cardiac life support. Advanced cardiac life support is the set of clinical interventions for the urgent treatment of cardiac arrest, arrhythmias, stroke, and other life-threatening medical emergencies. It goes beyond basic life support, or BLS, and involves advanced airway management, medications, and other advanced interventions. Now, why do we need ACLS? The primary purpose of ACLS is threefold. 1. Resuscitation. This is the act of reviving someone from unconsciousness or apparent death. In the context of cardiac arrest, this means getting the heart to start beating effectively again. 2. Return of spontaneous circulation, often referred to as ROSC. This is a term we use when the heart starts to beat on its own after a cardiac arrest. It's a sign that our resuscitation efforts are working, but it doesn't mean that our job is done. Post-ROSC care is vital to ensure that patients have the best possible chance of having a good outcome. And then number 3, addressing the reversible causes. Often referred to as the H's and T's, these are the potential causes of cardiac arrest that we can potentially reverse with the right interventions. By identifying and then treating these causes, we can not only get the heart beating again, but also prevent another cardiac arrest from happening. ACLS has a very structured approach. Remember, there's 3 basic principles. 1, circulation first. Before anything else, we need to ensure blood is circulating throughout the body. This means starting chest compressions immediately and ensuring that they're very effective. Airway is second. Once we've started compressions, we need to ensure that the airway is open and clear. This might involve using advanced airway devices or other techniques. And then finally, breathing is third. With circulation and airway addressed, we can then focus on breathing. This can involve giving rescue breaths or using a bag valve mask, or even mechanical ventilation in some situations or other causes. But to wrap up this slide, I want to emphasize a very critical point. The quality and the immediacy of the CPR are paramount. Studies have consistently shown that excellent and immediate CPR can significantly improve patient outcomes, and that high-quality chest compressions should be started as soon as possible and should be prioritized in patients with cardiac arrest. As we begin to dive deeper into ACLS, it's crucial to understand the primary cardiac rhythms associated with cardiac arrest. These rhythms are going to dictate our interventions and can mean the difference between life or death for our patients. So starting off today, we'll be discussing the 4 primary rhythms that you may encounter during a cardiac arrest case. First, we have ventricular fibrillation, or VFib. VFib is a very chaotic pattern on EKG, and it's going to originate in the heart's lower chambers, the ventricles, right? So the heart's basically going to be quivering instead of contracting and pushing out blood. The rhythm is going to be shockable, so we can defibrillate these patients, and that way we can try to restore a normal rhythm for them. Next is going to be pulseless ventricular tachycardia, or pulseless VTAC. Pulseless VTAC is going to be that rapid heart rate that's also originating in the ventricles and is going to be more organized than VFib. Remember, in VFib, they're kind of just quivering, and then in VTAC, you actually have like contraction. However, it might be so fast that the heart's not filling, and so you're not generating really a pulse in the patient. The patient's not generating a pulse. And so it's not effectively pumping blood because of how fast it's contracting. This is also going to be a shockable rhythm. Moving on, we have asystole. We all know what this is. This is that flat line on EKG, and that's not going to be a shockable rhythm. Again, asystole is not going to be a shockable rhythm. Do not defibrillate these patients. And it's very important in patients who you can't defibrillate, such as asystole, to really focus on that high-quality CPR that we mentioned earlier. And then lastly, we're going to have pulseless electrical activity, often referred to as PEA. PEA is a bit deceptive. While there is electrical activity present on the monitor, there's no palpable pulse. The heart might look like it's working, even if you are performing an ultrasound. There might be some electrical activity, some contractility of the heart, but it's not going to be effectively pumping blood, and therefore pulseless electrical activity. Our primary intervention, again, is that high-quality CPR, and this is not a shockable rhythm. So we have VFib and pulseless VTAC, which are shockable, and then we have asystole and pulseless electrical activity, which are not going to be shockable rhythms. In summary, when you're faced with a cardiac arrest, quickly identify, is this VFib or pulseless VTAC, or is this asystole or pulseless electrical activity, and that's going to dictate your further management for that patient. All right, so here's an example of VFib on an EKG. As you can see, as I stated earlier, it's a pretty chaotic rhythm. There's nothing really discernible. It's very all over the place. You have these just QRS complexes repeating after each other, essentially, that are all of varying amplitudes on the EKG, varying heights. Is what I mean when I say amplitude. And you can see it's just all over the place, just chaos. Nothing's organized. And so that's what VFib looks like, ventricular fibrillation looks like on our EKG. All right, and here we have VTAC. Remember, VTAC is going to be wide. It's going to be like wide QRS. It's going to be fast, and it's going to be very regularly spaced. So you do have something that looks a little bit more organized than VFib, a little bit less chaotic. However, it's just this wide tachycardia, wide complex tachycardia that's regularly spaced. And if you see that, that's pretty much going to be VTAC until you can prove that it's something else. So always keep that in mind when you have these cardiac arrest patients. You put them on the monitor, and this is what you see. This is VTAC until you can prove that it's something else. All right, on this EKG, you can see there's two sinus beats, pretty bradycardic, but two sinus beats, and then right where this arrow is at on screen, the patient goes into asystole. They flatline right where that arrow is at. And so this is what asystole looks like, just no cardiac activity at all, no electrical activity at all on the monitor on EKG. And then lastly, this is just an example of what pulseless electrical activity might look like. Remember that pulseless electrical activity can be any kind of electrical activity, and so it can look kind of like anything on EKG. But remember, they're not going to be it's not going to be a patient where you have an identifiable rhythm, and they're not going to have a pulse. So this is pulseless electrical activity, just one of the many examples of what this could look like. All right, on this slide, we have an overview of the ACLS pathway. So your patient has a cardiac arrest. You can see that over to the left. That's our start point. And you're either going to decide, is this VFib or pulseless VTAC? Is this going to be that pathway on top? Or is this PEA or asystole? And you're going to pick that pathway on bottom. And this is obviously assuming that this is a cardiac arrest while the patient's on the monitor. This is an in-hospital cardiac arrest. If you were out, at the grocery store or something, you would just immediately start CPR. Remember, immediate CPR is going to be huge for making sure that our patients have really good chances of having positive outcomes after a cardiac arrest. But if you are in the hospital and the patient comes in, you put them on the monitor, and this is what you have to decide. Do I go down the VFib pulseless VTAC pathway, or do I go down the PEA asystole pathway? And so let's start on the VFib pulseless VTAC. So you've started CPR, and you're going to do that for a couple of minutes. And then you're going to very, very, very quickly do a pulse check every 2 minutes. It's kind of been the standard practice for a long time. There's some literature coming out that essentially states that you should stay on the chest. You should continue doing chest compressions because we're actually very bad at at feeling for pulses. A lot of times we'll either be missing the pulse, or we will be actually feeling our own pulse because these are very, high adrenaline situations. And so that's kind of what you have to decide as a clinician. Do you want to stay on the chest, or do you want to pause for a quick pulse check? And if you do pause for a pulse check, make sure that it is a very fast pulse check. Now, this is something that I personally advocate for in institutions that have it. I think that's a great place where ultrasound can come in because you can use ultrasound to detect a pulse, to detect like an arterial flow, or to detect cardiac activity. Even in patients who have had asystole, you can say, oh, well, now there's organized cardiac activity on ultrasound. So that's just like one thing that you can kind of throw into your utility belt. But I'll get off my soapbox off my soapbox about that, and we can keep going. So after 2 minutes, you're going to shock the patient, defibrillate the patient, and then you're going to think about doing airway, and you are going to have administered epinephrine. You're going to administer that ASAP, and that's going to be every 3 to 5 minutes. So basically, if you do this in 2-minute increments, it's every other pulse check. And so then you go 2 minutes. If they still don't have ROSC, you can shock them again. You can consider giving them amiodarone. You can consider giving them lidocaine. And all this time, you're providing this high-quality CPR. You're giving the people feedback who are providing the CPR. And you're also going to be addressing your H's and T's, which is what we're going to be talking about next. Remember, that's those reversible causes that we can help out. And so you're basically going down this pathway of every 2 minutes, shocking them in between providing CPR, and considering giving them other medications for the reversible causes, as well as amiodarone and lidocaine to try and get them out of VFib or pulseless VTAC. And so that's what I kind of call pathway 1 as identifiable electricity. And then pathway 2 below that, I kind of call that unidentifiable electricity, just because PEA is in there, pulseless electrical activity, and then asystole is no electrical activity, so it is also unidentifiable electricity to me. And that's why I kind of call that pathway 2. That's why I refer to that way. And the similarities between pathway 1 and pathway 2 are, again, high quality CPR, epinephrine every 3 to 5 minutes, and then you're also going to be thinking about reversing those H's and T's, those reversible causes. And so you're going to start the CPR, but you're not going to be shocking them. So you're just going to be doing continuous CPR, epinephrine, and then trying to reverse those H's and T's if you can, checking for ROSC, things of that nature. It's essentially the same thing without the shock and without the amio or lido. You're going to be giving different medications to reverse your H's and T's, and providing epinephrine as soon as you can, and then again every 3 to 5 minutes. So that's kind of a general overview of the ACLS pathway. You can find probably a better graphic online from the American Heart Association. They have a really great graphic that's I highly encourage you to study with. It's phenomenal, but for the purposes of this lecture, I thought that this was a very suitable graphic for everybody to have and to use moving forward. So remember, I mentioned earlier, it's very crucial to understand that not all cardiac arrests are due to primary cardiac causes. There are several reversible causes, again, those H's and T's, that we can use if we can identify them and treat them to have good outcomes for our patients and reverse that cardiac arrest. So on this slide, we'll focus on the H's of reversible causes. First is hypovolemia, so a decrease in the total volume of blood or just general volume circulating in the body, which can lead to a cardiac arrest, maybe such as in a hemorrhage. The immediate action is to establish vascular access, IV or IO, whatever is available. If you can't get IV, go IO. And then once you secure that access, you need to provide fluids or blood products to restore that blood volume. The next one is hypoxia. So a lack of oxygen can quickly lead to a cardiac arrest. And in those cases, it's very imperative to supply the patient with the oxygen that they're missing. This can be done using a bag valve mask, a nasal cannula, maybe an advanced airway is required. It just all kind of depends on the situation. The third one is hydrogen ion, which is a little bit of a cheat in the mnemonic, but it stands for acidosis. So hydrogen ion, H+, and acid. So acidosis, that accumulation of any kind of acid in the body, can be very detrimental to our heart's function. So if you suspect a respiratory acidosis or a metabolic acidosis, you just obtain an ABG, an arterial blood gas, and get that done stat. And that can help you to ensure that the patient has adequate ventilation if it's respiratory, or it can help you to identify any other kind of metabolic acidosis that you can reverse, maybe by giving them bicarbonate. And so that can help you to reverse acidosis and reverse cardiac arrest in those patients. The fourth is hypo or hyperkalemia. Remember that potassium imbalances are very dangerous, can cause a lot of that specific electrolyte derangement can cause a lot of really bad cardiac arrhythmias. So remember, if they're hyperkalemic, you might want to give them some calcium to stabilize the membrane of the cardiomyocytes. And then for hypokalemia, you can give them the potassium that they need. Number 5 is going to be hypothermia here. So remember that if a patient gets really, really cold, maybe they're starting to get frostbite. This isn't something you would normally see unless it was in the winter. You might see this in your homeless population. Someone found down off the street with cardiac arrest. They look disheveled. They look like they might be homeless, and they were out sleeping on the street overnight. When it got really cold, they became hypothermic and had cardiac arrest. That's something that you might see in clinical practice. So it's going to be very imperative for you to raise their core body temperature. You can use passive or active rewarming in order to try and reverse that cardiac arrest. And so it's also very important right here. I'm going to pause to say, remember that you cannot actually pronounce someone dead until you have rewarmed their core body temperature up to a normal body temperature, because that hypothermia can cause the cardiac arrest and can cause essentially the patient to mimic looking like they are dead. So that is one of the criteria before you pronounce someone dead, is making sure that their body temperature was within the normal limits. So in conclusion for this, remember these reversible H's. Run through those during a cardiac arrest. Think about what you might be missing. Think about what kind of orders and labs you can order stat to make sure that you're ruling out everything that you could possibly reverse on this patient, and what interventions can you do to reverse those H's even if you can't see them up front. All right, next we'll focus on the T's of the H's and T's and our reversible causes. The first is tension pneumothorax. So immediately you can needle decompress these patients. Oftentimes they may have an asymmetric chest rise. If you shoot a chest x-ray, you'll be able to see the collapsed lung. And they'll also be in tension physiology. So make sure that you're covering all of those things whenever you think about tension pneumothorax. You can see a lack of lung slide on ultrasound, or you can find a lung point. That might help you to identify that the patient has a pneumothorax. But again, remember, this is in the setting of tension physiology. So you can do a needle decompression, which may be done in the field if the EMS is able to identify this. And then you may also end up placing a chest tube on these patients to prevent recurrent pneumothorax from happening. The next T is tamponade, as in cardiac tamponade. So this will be identified typically on ultrasound in the emergency department, or if you're in the ICU, you may be able to identify cardiac tamponade in a patient who's gone into cardiac arrest. And so pericardiocentesis is often the procedure of choice to fix this. And so that's going to involve aspirating the fluid from the pericardial space, relieving it so that the patient can go up for a pericardial window, oftentimes with surgery. And if they are stable enough, obviously they haven't crashed and they haven't had a cardiac arrest, sometimes these patients will get pericardial windows if they have a very large effusion and they're not looking so hot. They'll go ahead and get this pericardial window done with surgery anyways to make sure that they don't develop or go into cardiac tamponade. Number 3 is going to be toxins. So any kind of ingestion or overdose, you're going to want to identify that toxidrome and then reverse it. For opioid overdose, maybe you're using, naloxone or Narcan. to reverse that. And so for some toxins, remember that you're just going to be giving the patient supportive care. That's all we have for some toxins. And then number 4 and 5 are both thrombosis. This can be thrombosis of pulmonary origins, such as a PE, in which case maybe the patient needs thrombolysis or thrombectomy in order to reverse this. And then also it could be of coronary origins, so maybe they need PCI or thrombolysis to reverse this. Thrombus coronary etiology would be somebody who had a myocardial infarction, essentially. And hopefully you would be able to identify that beforehand and get them to the cath lab beforehand, before they crash, before they have cardiac arrest. That would all be ideal. But just remember to run through these T's as possible etiologies of your patient's cardiac arrest that you could reverse and help to save their life that way. So here's a quick review slide of all of the H's and T's. Remember, we have hypovolemia, hypoxia, hydrogen ion, which stands for acidosis, hyper or hypokalemia, and then hypothermia. And then for our T's, we have toxins, cardiac tamponade, tension pneumothorax, thrombus, such as a PE or of pulmonary origins, and then thrombus of cardiac origins, such as in a myocardial infarction. All right, so now it's time for the plus part of the ACLS Plus lecture. So in the coming slides, we'll go over things such as SVT or supraventricular tachycardia. We'll go over torsades. We'll cover AFib, a flutter with rapid ventricular response, and we'll also cover bradyarrhythmias. All right, so first things first, supraventricular tachycardia, which, as the name suggests, is characterized by an abnormally fast heart rate, and the origins are going to be above the ventricles. And what differentiates it from other tachycardias, again, is that origin from above the ventricles. When we talk about tachydysrhythmias, SVT is going to be the most common one. The prevalence is going to kind of underscore its importance. It's the most common one, so it's very important to have this and be aware of how to manage this. Have this in your brain. The most common cause, again, is going to be this orthodromic re-entry phenomenon. I'm not going to go into detail about what that is, but I do think it's worth reading about. But essentially, you get like this circular electrical pathway that's aberrant or abnormal going on inside your atria, and so that's worth looking into on what a re-entry circuit is, so that you can kind of conceptualize this better. But either way, it's going to lead to these rapid heart rates, and that's going to kind of help us with our therapeutic approach, knowing that it's this supraventricular re-entry circuit. So patients with SVT present a lot of different ways. Some may experience anxiety or say they're having the palpitations. Some may say that they have feelings of like their heart racing, which is still palpitations. They may say that they have chest pain. They may feel short of breath. Others might actually have syncopes. They may have passed out due to this tachydysrhythmia. And so in severe cases, patients can actually come in with hypotension. They can actually be unstable because of this tachydysrhythmia. So there's a large spectrum of how patients can present with SVT. Now, managing SVT requires a systematic approach. You can try initial interventions like vagal maneuvers or carotid massage, but the classic teaching in our classic intervention with medications, as long as the patient is stable, is going to be giving the patient adenosine. And you're going to administer that 3 different times in doses of 6 milligrams, 12 milligrams, and 12 milligrams. And so you will do that, and you will hopefully reset the patient. If they don't get reset from that, if they don't go back into a sinus rhythm, you can try to rate control them, and then our last ditch effort is to pace them or to synchronized cardiovert them, which is different than defibrillation. Synchronized cardioversion is different than defibrillation, but that's kind of our last line on patients who are stable. If the patient is unstable and they have SVT, you should try synchronized cardioversion first. So that's kind of covers our background and our treatment algorithm for supraventricular tachycardia. Next up, we have torsades, which is going to be a polymorphic ventricular tachycardia. So I want to talk about the term polymorphic briefly because that's really going to help you identify and separate torsades from other arrhythmias such as VFib or VTAC. And so the term polymorphic really characterizes this arrhythmia. And so you're going to have an oscillation or a change in amplitude where the amplitude of the EKG is smaller and then it gets bigger and then it gets smaller again. And that's going to repeat small, big, small. And you can kind of see that happening a little bit on the picture that I have on this slide. And so people have described this previously as giving this twisting appearance like ribbon around a pole. And so it gets its name, torsades de pointes, actually is French and means twisting of the points. So if you imagine these 2 points and you have this ribbon between it and they're twisting. And so that's kind of where the name comes from. And I think if you know that and you understand that, it can help you to identify this arrhythmia on EKG or on a monitor. And the epidemiology of torsades is closely linked with congenital long QT syndrome because congenital long QT syndrome really puts people at risk for developing torsades. And so there is a little bit of a gender difference in prevalence. Males are more commonly affected than females. And this distinction is somewhat crucial for clinicians to recognize because it can guide some diagnostic considerations. But overall, congenital long QT syndrome is pretty rare. Not something that you would encounter very often in clinical practice unless you were a cardiac specialist. However, one classical historical thing that you should be aware of is there is this situation where people with congenital long QT syndrome will dive into a pool and that will actually send them into torsades and then subsequent cardiac arrest. And they will actually drown and die after having dove into a pool. And so someone in a potential question stem on your STEP exams, someone may have a family member who dove into a pool or they themselves dove into a pool and they died. And that is your trigger to think about congenital long QT syndrome in the patient that they're asking you about. So that's just a quick hit, kind of as an aside for your STEP exams, but something that I think is worth mentioning because it is something that does pop up from time to time. The most common cause for this is actually theorized to be, not known for sure, but theorized to involve some sort of inhibition of the delayed potassium repolarization channels in our cardiac myocyte cycle for their depolarization-repolarization cycle. So to kind of simplify that, there's essentially this delay in the heart's electrical recovery, which is going to predispose them to torsades. The clinical presentation, again, is quite varied. Most of these patients are going to be asymptomatic because they'll go in and go out. You know, they'll go in to torsades, they'll have symptoms, and by the time they get to the emergency department or to the doctor's office, they're no longer in torsades, and so they're asymptomatic upon presentation. Some people might also experience syncope, so that temporary loss of consciousness, and that will bring them into the doctor's office or the emergency department. And some people may say they're having palpitations. This may cause dizziness. And then, of course, in really severe cases, it can lead to sudden cardiac death and cardiac arrest, and then you go into your ACLS protocol. So when it comes to treating torsades, if somebody is in torsades on the monitor, on the EKG in front of you, the first line drug that you're going to administer is going to be magnesium. And that's going to be like 1 to 2 grams over the course of 15 minutes. And the hope is that that's going to stabilize their electrical cardiac activity. And then a second line drug would be amiodarone, and you can give them 300 milligrams up front, and then the subsequent dose would be 150 milligrams. And it's just like SVT. If a patient is unstable, if they're stable, you should treat them just as I talked about. However, if they're unstable, you should do synchronized cardioversion on that patient first. So stable, treat them with the medications, magnesium, amiodarone. If they're unstable, do synchronized cardioversion. Next up is going to be AFib with RVR, or rapid ventricular response. And so this is going to be characterized by that irregular and rapid contraction of the atria, essentially where they're quivering instead of contracting. And that irregularity is going to cause the ventricles to beat faster than their normal rate because they're really trying to get blood out, even though they're not receiving as much blood as maybe they should be from the atria. And so it's going to be like this chaotic storm in the atria, leading to this unpredictable and often rapid ventricular response. And AFib overall is not that uncommon. The estimated prevalence in the United States is somewhere in the 1 to 2% range. And that's, again, going to mean for every 100 people you meet, 1 to 2 of them are going to have experienced AFib at some point throughout the rest of their lives if they haven't already. And the most common causes can include advanced age, heart disease, and these patients may have any range of heart disease, including like valvular diseases, coronary artery disease, just a very broad umbrella to say that, if they have other heart problems, that's probably going to predispose them to atrial fibrillation as a subsequent issue. Patients with AFib or A-flutter may experience chest pain or palpitations. They may feel short of breath. They also have, again, a pretty variable range of presentations. They can be completely asymptomatic as well whenever this is found and diagnosed. Overall, should be pretty easy to remember how to treat them. There is one special case that we're going to talk about though, but the primary goal in treating this arrhythmia is going to be to control that rapid ventricular response, ensuring that the heart's not beating too fast so that the ventricles are filling and they're actually pushing out some blood. The first line drug is often diltiazem, that calcium channel blocker, and you can administer a bolus of like 0.25 to 0.35 mg per kg. You're not going to be expected to know that on your step 2 exam. I've just included it here for completion's sake. And then you can move on to esmolol after that. You can even move on to metoprolol. Digoxin can actually help with rate control. I believe this is due to vagus nerve activation, but you would have to double check me on that. I don't remember 100%. You can also consider amiodarone in these patients, but the last line is going to be cardioversion. Some people will use cardioversion first, and this is going to be that special case that I talked about. So if you have a new onset of AFib, this patient comes in, hey, 4 hours ago, I started feeling these palpitations. My chest is hurting now. I'm really scared. So I came to the emergency department. I came to the doctor's office, wherever it is. So they've had symptoms for less than 48 hours, right? You can actually cardiovert them first if you want. However, if they have never had this before, never been diagnosed with it before, and they say, hey, like 2-3 days ago this came in and it's been greater than 48 hours, remember that those patients need you'll get a transthoracic echo first, but they're also going to probably need a transesophageal echo to diagnose AFib and to look for any clots in their atria that have happened due to the stasis of the blood in the atria that are just quivering rather than contracting. And then they're going to need anticoagulation for 3 weeks before they can be cardioverted out of AFib. And that's to avoid any sort of emboli or thrombus, emboli breaking off from some sort of thrombus in the atria and traveling somewhere where you don't want emboli to go. And so that's sort of the thought process on that. And that special case is something that pops up, I feel like, quite frequently on step 2 question banks and practice exams because it's an easy trick for you. New onset AFib, greater than 48 hours. Make sure you get a transthoracic echo. Make sure you get a transesophageal echo. Make sure you rule out any kind of thrombus in the atria. And then you anticoagulate them for 3 weeks before you cardiovert them out of AFib. So that's kind of all I have to say about AFib. We can move on to a flutter with RVR now. And in contrast to AFib, a flutter is going to present with this regular, not irregular, but regular rapid contraction of the atria itself. And that's also going to cause the ventricles to beat faster than they normally would. So imagine there's like this consistent rapid drumbeat in the atria, and that's just going to be driving the ventricles to just respond really fast. But you're going to treat this the same exact way that you treat AFib, so I'm not going to spend any more time on this slide. On this screen, on the left, we have an example of AFib. They're not in RVR. Their actual rate is pretty decent, so RVR might be a little faster than that. But the big thing is they're in AFib. There's no P waves, no identifiable P waves anywhere on that EKG. And then you move over to the right, and we have a flutter where instead of having regular P waves, we notice this sawtooth pattern going throughout the EKG where the P waves normally are. And that sawtooth pattern is kind of the hallmark of atrial flutter. But again, treat this the same way that you treat AFib with RVR. All right, so we've talked a lot about fast rhythms, so things that are tachydysrhythmias. Let's talk about bradyarrhythmias, which is going to be referring to heart rates that are slower than they should be, typically less than 60 beats per minute. And that's just not about a slow heart rate, though. It's going to be about what is causing that heart rate to be irregular. So it's essential to differentiate between simple bradycardia and an actual bradyarrhythmia, because some people will go to sleep and they will be bradycardic, but that's not a dysrhythmia for them. For example, my heart rate monitor on my watch that I wear when I sleep tells me that my heart rate gets down into the 40s. I don't think I'm having any kind of bradyarrhythmia, though. I'm just bradycardic when I sleep. And so it's very important to differentiate between those two things, because it can be normal or there can be an irregularity causing the slowness. So the most common cause of bradyarrhythmias is going to be some sort of heart disease or damage that predispose the patient to this dysrhythmia, similar to what I talked about earlier. And these patients can also present with a variety of symptoms such as chest pain, dyspnea, syncope or presyncope, dizziness. They can, if they've had this bradydysrhythmia for a while, they can actually be fatigued from it. And so when it comes to treating that, we have several options. The first of which is going to be atropine. It's often going to be your first line treatment if a patient's having a bradyarrhythmia in front of you. And you can dose them with 1 milligram of atropine every 3 to 5 minutes. Again, you're not going to be tested on dosing on step 2. It would be very unlikely, I think, for them to ask you that. However, again, included it here for completeness sake. If atropine doesn't work and doesn't get them out of that bradyarrhythmia, you can actually do transcutaneous pacing, which is this non-invasive method where pads are placed on the patient's chest to deliver like these small electrical impulses, hopefully helping the patient go into a normal sinus rhythm out of this bradyarrhythmia. There are times where people will do transcutaneous pacing and they will actually add a little bit of dopamine or epinephrine to that treatment regimen to get the patient where they want the patient. And so that's an option as well. And then if that doesn't work, you can go to transvenous pacing, which is actually a little bit more invasive of a procedure. But essentially you're placing a wire and threading it into the heart via a vein, usually like your subclavian or femoral veins. And that's going to allow for direct stimulation, direct electrical stimulation of the heart itself, of the myocardium itself. And so again, similar to in our other dysrhythmias, or tachydysrhythmias, if the patient is unstable, we're going to actually go straight to pacing them. We're going to skip the atropine, go straight to pacing them. And so remember, stable atropine first, unstable pacing first. And then a small little blip on the slide there. If this is second degree AV block type 2 or third degree AV block, or if it's idioventricular rhythm, you can skip to the pacing just because the likely etiology of that is going to be infranodal, and so atropine won't work as well. And so if that is the etiology of the Brady dysrhythmia, you can also, those are also indications to possibly skip atropine as an intervention. So that's just a small thing to keep in mind, something they may be able to trick you with on your exams. Finally, on this slide, I have created a flow chart of non-cardiac arrest interventions. And so you just see, is this cardiac arrest? No. Well, then is it fast or is it slow? And you can kind of go through the flow chart. In the show notes, there are going to be links to PDF as well as to an image of a complete summary, a complete flow chart of everything we've talked about in this lecture. I highly encourage you to look at that to help you kind of organize your thoughts about going through, is this cardiac arrest? Yes. Should I go through ACLS? Which part of ACLS? And then is this cardiac arrest? No. Okay. Is it fast or slow? How do I manage this patient? How do I identify the rhythm? What are the interventions I should be doing? And so those are things that I've provided for you again in the show notes. I highly encourage you to use that as a study tool if it helps you. And then finally, I understand that not everyone has immediate access to sim labs or mannequins every single day of the week. But thankfully, we live in a digital age where there's resources available, and I've listed them here, where they basically have free code simulators. And so those simulators can really be instrumental because this is something that is practice makes perfect for all of these cardiac emergencies. And I understand that nothing's going to replace any sort of hands-on training with a patient or with a very lifelike mannequin in a sim lab, but these online simulators are going to be offering convenient and effective ways to kind of practice and refine your skills and test yourself. And so I highly encourage all of you that are listening to explore these websites, to use them if you feel like they're going to benefit you so that you're a little bit more prepared in clinic, in the real world, in an ICU setting, in an emergency setting, wherever you might encounter these kinds of cardiac arrhythmias or cardiac arrests, so that you can be ready, be prepared, and really make a difference in the lives of your patients. All right, that was a very long lecture, but thanks for tuning in. And remember again to like, comment, and or subscribe so that we can continue to provide free medical education resources to students all around the world. Also, please feel free to drop any feedback so that we can continue to improve our lectures. Have a great day.